Hi, welcome. We're so glad you've joined us today. This is a part of the series that we've been doing for NICU family advocates, parents, and professionals. It's on the psychosocial support of NICU parents. And today we're going to be talking about the section of the recommendations that is about mental health professionals in the NICU. This is one of 6 recommendation sections, 6 domains that are covered. These were initially published in the Journal of Perinatology in a special supplement that's open access that was published at the end of 2015. And this work, this publication, is the culmination of more than a year of work that the National Perinatal Association did in collaboration with numerous other organizations involved in perinatal health care and in advocacy. We wanted to sit down and highlight the importance of psychosocial support for families. But more than just talk about its importance, we wanted to create something that told people how to go about implementing these sorts of programs. When we created the guidelines, we divided it up into 6 areas or domains. We have done and are recording and have done several webinars, and we're doing one that's an overview, and then we're doing one on each of these 6 sections that's covered in the recommendations. So again, today's webinar that we're doing is about mental health professionals in the NICU. We're going to discuss a couple of things. Again, this is based on not just describing why something is important, but really taking what has been said and what we know from the literature and what we know from the research and putting it into action. So we'll talk a little bit about why this is important, what the rationale is, what the research says, and then we'll talk about the recommendations, but more importantly, what you can do to support them, to advocate for them, and to make sure that these things are implemented so that both NICU parents and the staff who work with them get the support that they need. I'm one of your hosts, Erica Goyer. I'm with the National Perinatal Association, and I'm joined today by my co-host, Allie Dunn. Allie Dunn is the mother of micropreemie twins, and she's also an accomplished author who has written several books, including I Was a Preemie Just Like You, One of Two, which is about her twins, and The Career Explorer. Our presenters today are Dr. Sage Saxton and Dr. Mike Heinen. Dr. Sage Saxton is an associate professor of pediatrics at Oregon Health Science University in Portland. That's where she directs their NICU follow-up program. She's also the chair of their developmental care committee, and she develops programs that are meant to improve family and patient-centered care in their NICU. Dr. Saxton was also one of the authors on the section that we're going to be talking about today in the Journal of Perinatology. She went on from that to go ahead and collaborate on the NICU staff education course and resources that we've done around the guidelines. And she also is one of the co-chairs of MPA's NICU psychologist group, which is the group that Mike Heinen, Dr. Mike Heinen, helped to create. Dr. Heinen is really one of the great forebearers of the research that we do around psychosocial support for NICU parents. He is a parent himself. His son, Chris, was born at 30 weeks, and Mike and his wife spent a lot of time having the NICU parent experience. That experience went on to continue to inform his research that he's done. He's done a lot of work around the impact of a NICU stay on parents' mental health care and how it influences their mental health care needs. He's written a great deal about PTSD and has really done some wonderful work on the special attention and considerations when supporting fathers of babies who have been in the NICU. Dr. Heinen is on the editorial board of the Journal of Perinatology, but he is also the co-creator of these guidelines and recommendations, which really were a project that came out of passion and love for our community. And he and Dr. Sue Hall really championed this project and have continued to champion interventions for NICU families. So we're going to talk today, I guess, from the beginning with, why is this important? As you looked at what was going to be in the recommendations for the psychosocial support of NICU parents, why was mental health care or mental health care professionals in the NICU something that was important?
Well,
Dr. Saxton.
thank you. Thank you, Erica and Ali, for inviting me on. And I wanted to take a moment to specifically thank Dr. Heinen for inviting me to assist with the creation of the psychosocial support of NICU family guidelines, and for both the shared visions of Dr. Heinen and Hall in their creation of this amazing and critical compilation. So to specifically answer your question, the NICU was originally designed to serve babies who were sick or who had early complex medical needs. But as our care for these babies has moved beyond life-saving heroic measures, we've realized there's a lot of work that needs to be done with the family as well. Our common sense, of course, will tell us, as will research, that parents with babies in the NICU will experience great distress, and they're going to require some support. We know that within the first year alone, it's anticipated that maybe between 20 and 30% of NICU parents will develop depression, anxiety, obsessive compulsive disorders, acute stress disorders, and or post-traumatic stress disorder. When we look at this set of 5 disorders, they're collectively being referred to in the medical field as perinatal or postpartum mood and anxiety disorders, or PMADS. And I'm going to use the term PMAD throughout the presentation, but be aware that there is some movement to getting rid of the PMAD part. There's some discussion there. So these PMADs represent a spectrum of mood changes that families face during or after pregnancy. And this PMAD is in addition or further complicating the other continual stressors for NICU families. And some of these stressors can include financial strain, family relationship strain, and adjustment stress. PMADs, in fact, are the #1 complication of pregnancy and childbirth. And further complicating that is that in the NICU really wasn't a part, or is seldom a part, of a family's birth plan. What happened, unfortunately, in the late 90s, a study in the United Kingdom found nearly half of women in their sample who would later go on to screen high on a rating scale called the Edinburgh Postnatal Depression Scale. So nearly half of those women were not identified by any member of their primary healthcare team, despite an average of 14 contacts. So in addition, it's found that nearly half of the women with PMADs don't get treated. So this is an ongoing systemic problem. We know that untreated PMADs will also have a societal cost. It's estimated that over $14 billion is spent annually on untreated PMAD. And that data, I think, was 2017. So those costs have likely gone up in the last 2 years. And most of those costs are related to employers and healthcare providers. And finally, there's a vicious cycle that gets created in the NICU when you have a NICU parent faced with a very sick or low birth weight baby, which then leads to parental distress and depression, which then leads to impaired bonding with the baby, which then leads to poor developmental outcome for the baby, which then leads back to that increased depression for the parent. And if left untreated, this cyclical, vicious cycle will continue over and over again. What we know is having a psychologist in the NICU can help with increasing the identification of these at-risk families through improved screening and intervention. And it can also help reduce, that psychologist can hopefully reduce some of these later societal costs. And there's certainly a lot of developing momentum in this area. And the National Perinatal Association's NICU psychologist group that Erica had mentioned in the introduction is hearing from psychologists around the country who are really becoming interested in working in the NICU. I think it's important to realize that all families deserve this higher level of support and care. And of course, the end result of providing these interventions and these screenings will be the creation of stronger, healthier families.
Yeah, Dr. Sachs, I mean, it's really fascinating. I know that, there's a lot of focus now on how families are doing, how parents are doing, especially during now what we're calling the fourth trimester, after
Mhm.
a baby is born, and yet how the NICU sets things up. So it's, the perfect storm. So as high as the prevalence are for these mood and anxiety disorders for any parent, in fact, I think you and I have talked about how for many people, this is the first time they ever really have um, a mental health condition emerge is in the postpartum period. So then you add the NICU to that, and again, it's the perfect storm.
Absolutely.
Yeah.
Absolutely.
Well, again, it's very exciting that these needs are being recognized, and then the question is really, what do we do about it? And what makes it all the more complicated, I think, in some ways, is that this is a relatively new field. The focus is um, really highlighted right now, but even our understanding about all these mood and anxiety disorders is relatively new. And Dr. Heinen, I know you've been working on it for a while and describing these needs, but can you give us just kind of a brief overview about how understanding a parent's needs has evolved, especially in relationship to the NICU?
Certainly, thank you. And Sage, that was an excellent review. It seems as that as I get older, I kind of get assigned the role of historian. And 39 years ago today, my son Chris was in day 28 of his NICU stay.
Mm.
Like almost all NICU parents, I felt as though I'd been hit by a train, both physically and emotionally. And I remember about day 4 or 5, I asked a neonatologist about what could I anticipate in terms of emotional reactions, both for me and for my wife. And I got no answer. That was my first clue that something seemed to be missing. Even if I had gotten some information, I'm not even sure, even though I was a baby clinical psychologist at the time, that I would have been able to do anything to prevent my wife's depression. But I started to look for more clues, and I found more when I began attending regional and national meetings of NICU parents. In addition to hearing stories about depression, I also heard about symptoms of post-traumatic stress. And I decided, well, it's time to do some research. The first journal publications on PMADS really didn't start to appear until about 25 years ago. And it took until 10 years ago for there to be a sufficiently large database to convince the leadership in most NICUs that a NICU experience was a potentially traumatic one for parents. Early on, it seemed to me that it was only the most sensitive of the chiefs of neonatology who recognized the NICU's need for an expertise in psychology, in addition to that of the social workers, for the benefit of parents in the unit. These leaders then began to hire psychologists and other mental health professionals, largely out of their discretionary funds at the beginning. Once there was only a handful of psychologists working in the NICU, and now there are over 100. The NICU even now gets Benny points from the US News and World Report in terms of their quality rating scales if they have a psychologist on staff. So today, the extent of the emotional needs of parents is now really impossible to ignore.
Mike, this is Allie. I was wondering if you'd be able to provide us with a brief overview of what readers can expect to find in the guidelines if they're not real familiar with them yet.
Sure. Well, first and foremost, and something consistent with the foundation of National Perinatal, the guidelines were created by a multidisciplinary group, or Nowadays, folks are using the terms transdisciplinary or interdisciplinary, whatever your choice of word is. But within the multidisciplinary approach, really most importantly, was that within each of the 6 groups that were shown in a previous slide, each of those groups had recommendations that had significant input from NICU parents. Within the mental health recommendations, there are specific recommendations about space in the NICU, both space for private conversations among family members and mental health professionals, and larger areas for parents to be able to gather in groups for social and educational functions. We have recommendations about staffing for NICU mental health professionals. These largely follow from the National Association of Perinatal Social Workers standard of 1 social worker for every 20 NICU beds. We recognize that smaller NICUs may not be able to hire a full-time psychologist, but in those cases, we recommend a part-time psychologist dedicated to the NICU, or perhaps a psychologist from the behavioral health section of the hospital who can spend some time in the NICU. In a little bit, Sage will be talking about some NICU parents who may need more intense therapeutic levels of what we call clinical psychological care. It will help those NICU parents the most if the therapeutic sessions can occur within the NICU. Referrals to therapists outside of the NICU place additional burdens on parents who are reluctant to leave their baby. Implementing the recommendations requires coordination among the mental health professionals in a particular NICU that takes into account the unique skills of each person, each profession, and activities that will probably overlap. Our recommendations also emphasize that the stress of a NICU experience should be normalized for all parents and caregivers. I've learned over the years from conversations among NICU psychologists that a wonderful way for a psychologist to connect with parents is to have dedicated time to walk through the NICU and engage all parents that are available. One NICU psychologist introduces herself by saying her name and then stating, "I'm a psychologist and I talk with all the parents." She then begins a conversation, asking about the baby, and encourages the parent to share impressions. She's able to start an ongoing relationship and communicate in a variety of ways that the NICU staff recognizes that this is a stressful time for all parents and that all parents and family members will be cared for. It does take a village. In addition to providing clinical services for parents and family, most psychologists also have the skills to conduct research in the NICU and to help with quality improvement projects. But very importantly, NICU mental health professionals can also be a great benefit for staff. One of the 6 sections of the overall recommendations is regarding staff education and support. Psychologists and social workers can provide sessions on recognizing signs of depression, anxiety, and post-traumatic stress in NICU parents. Staff education should also include sessions by mental health professionals on self-care for staff, avoiding burnout, and debriefing. And staff communication skills can also be fine-tuned with exercises in listening, building empathy, and giving non-judgmental feedback. So enough from me right now. We'll turn it over to you, Sage.
Thank you, Mike. That was a great overview. And as you were going through those guidelines, there were so many things I was thinking, gosh, I really wish that that would have been part of my NICU experience. It would have made things so much easier. Sage, what are some of the key points that you would like audience members to take from the section of the guidelines?
Yeah, great question, Ali. In relation to the key points, I think it critical, like Dr. Heinen mentioned, that all NICUs that have greater than or equal to 20 beds should have a master's level social worker. And the other component of that is or a full-time or part-time perinatally trained psychologist on staff. And the recommendation for the 20 beds MSW level social worker is really in line with the standards for social work services, where they state the NICU shall assure that staffing meets recommended levels of not more than 20 NICU active beds for each full-time equivalent master's level social worker. So we absolutely agree and endorse that recommendation. We would also like to see that full or part-time perinatally trained psychologist. And in addition, we want the NICU to have a position for a paid parent support coordinator in an ideal world. Secondly, it's also important to screen for PMADs. As we've been discussing, there is certainly a high prevalence rate of PMADs, especially for our NICU families. We know that screening tools are very readily available, and these tools, when presented appropriately and when we're normalizing and reducing the stigma related to these extreme emotions, which are very common, we reduce that stigma and we can help mitigate that negative impact and long-term consequences for families. And because of all of this, our guidelines specifically state that NICU parents should be screened for that emotional distress within the first week following admission, and also within 48 hours prior to discharge, because we know that those are very high points of stress, and that's at a minimum. More recent screening guidelines have even suggested the first 24 to 48 hours. And to not engage in such screening is really a detriment to our families. One thing that we will talk about is how when you do screen, it's important that you're aware of your available resources, both in hospital, ideally, and in the larger community. A third key point is that all parents in the NICU should receive layered levels of support. And a really nice model to describe that is Kaczyk's Stepped Care Pyramid, and this came out in 2006. So I want you to take a look at that bottom layer, the largest layer. Those refer to our universal supports, the supports that all NICU families can receive and have access to. This is our family-centered care model and our models of parent-to-parent support organizations, such as the Preemie Parent Alliance. And this is for all NICUs. We'd like all NICUs with greater than 40 beds, according to our guidelines, to have a weekly parent educational group. And notice I'm saying educational group versus support group. A lot of parents really do want more about education and information about what they're experiencing and what they can expect for their child and how they can help. Support group might sound a little too psychologically touchy-feely for some. And topics for these educational groups can include things like reading your baby's cues, pumping maybe a drag butt. Dad's tips for surviving and thriving in the NICU is really popular in our hospital, as is our Ask a Doc. When we have an Ask a Doc, we bring in one of our neonatologists to very candidly have discussions with our parents, and it goes really well. And these are, again, groups that focus on general information that will be useful for all of our NICU families. The middle tier, the next tier, a little smaller than the universal, is that targeted group. These are families who might benefit from some additional supports and services, families that might be in some acute distress and have some risk factors. These are the families that would certainly be identified, our hope would be identified on screening. And as we screen, it's important, as Dr. Heinen mentioned, to really normalize this for families. I meet with all families. I screen all families. And again, this would ideally happen very quickly following an admission. That final tier, the third tier, represents the smallest proportion of our NICU families. We're about 20 to 30%. And these are the families we were talking about earlier that are likely to experience a diagnosable disorder in the first year, post-traumatic stress disorder, depression, anxiety. And this clinical treatment group are the ones that really do need more support, ongoing work with a social worker, a psychologist, a psychiatric nurse practitioner, or a psychiatrist. And again, we really want to make sure those supports are happening as much as possible in the hospital near the NICU to provide the best access to the unit for families who are under a lot of stress. And if these services are not available in the hospital, it's really critical that hospital staff be made aware of how they can access these services in their larger community.
So, this is all very, very interesting. And it makes me think a lot about how, again, we talked about there's a kind of a new understanding of perinatal mood and anxiety disorders. And then, but beyond that, what a great need there is within our healthcare system for the integration between mental health care and general medical health care as we've thought about it in the past. And it makes me think, I mean, not only is this time in the NICU a time when people are especially vulnerable, or during the perinatal period where we talked about a lot of people first develop some sort of disorder, or at least recognize it, is that we know that a significant portion of the population, at least 1 in 6 people has a diagnosed mental health condition. And, that kind of sets you up for these sorts of things, but also the prevalence of, trauma and other things that can reemerge when either during the perinatal period or when something happens to your child and when you're in the NICU. And I think it just highlights, and why I love this work so much, is that the screening is integrated into the care that's being given. When Sage, when you mentioned at the beginning the idea that parents were having on average, 14 different contacts or, discussions, and yet their mental health was never being brought up, I think just illustrates how in the past we haven't recognized how important this is in the delivery of care in the medical setting. And so I think it's really important too that people understand more about screening. You talked about KZAC, you talked about the targeted levels of support, but I think we probably need to demystify it more beyond that idea that you have that general conversation of, hey, I'm introducing myself, we talk about this with everyone. I think it's good that we talk a little bit more now about what screening actually looks like and maybe feels like, give some anticipatory guidance, because I think that's still something that most people don't really understand. So Sage, you first, if you could talk about some of the screening tools, and then Dr. Heinen, if after she does that, if you can talk about, specific groups, especially fathers, and how screening is important.
Absolutely. So we know that PMADs can occur in roughly 14 to 20% of women and roughly 10% of men, and that's just for the general population. So when you start looking at a NICU population, we know that those prevalence rates are higher. Now, I want you to compare those percentages to gestational diabetes and hypertension. Both of those occur in around 5% of pregnancies, and those conditions are routinely screened for. So again, PMADs are the #1 complication of pregnancy and childbirth. And given this high prevalence rate, especially in our NICU population, we hope to screen all parents within that first week of admission. And again, more recent guidelines might even be within the first couple of days. And screening can be as quick as a 2-question screen that was presented by the U.S. Preventative Services Task Force. And their 2-question screen included, over the past 2 weeks, have you felt down, depressed, or hopeless? And number 2, have you had little interest or little pleasure in doing things? It can be that quick as a touch point. Other screening tools, such as the Edinburgh Postnatal Depression Scale that I mentioned earlier, the EPDS, are free, and the EPDS in particular has been widely used and is available in I want to say 18 different languages that have been validated, and many more that are in progress. And the EPDS is certainly something that psychologists have been using in the NICU as a quick screen for many years. It is the most thoroughly validated. As I mentioned, it's free as long as you cite the authors, And it's a quick 10-item self-report written at a 6th grade reading level. But one thing to note, and I think is very important, is that screening is not diagnostic. Screening, the EPDS in particular, is not linked to DSM-4 criteria or DSM-5 criteria, our Diagnostic and Statistical Manuals book, and it doesn't diagnose a PMAD. But
So
it
why
does.
is that important, Dr. Saxton? What is the distinction people need to understand between a diagnostic screening? You know, how does that relate to treatment?
I think it's a really good question. A diagnostic screening tool doesn't exist. The screening tool is out there to identify symptoms and concerns for that family member that, in collaboration with more in-depth interview, psychological or expert opinion, information from background and history, that could be used to make a diagnosis. But a high score on the measure itself does not indicate that that parent has depression, as an example.
Right.
And once we identify the symptoms and difficulties for that particular family, we can then provide those targeted levels of treatment support, either ideally in the hospital or out of the hospital.
I love it too, because it gives just context to what it is that a family might be feeling.
Absolutely. And again, we know these feelings are so common. This is not unheard of in the NICU. And by identifying our families, we can provide those supports. So I think one thing to be aware of is some of these screening tools do have varying cut points. So on the EPDS, you can look at a total score. For women, there are guidelines for women and developing guidelines for men. Women have minimal or very few depressive symptoms with a total score of between 1 and 6, mild between 7 and 13, moderate symptoms between 14 and 19, and then scores between 19 and 30 for women on the EPDS indicate real severe depressive symptoms. Again, not diagnostic. Now for men, the EPDS was originally designed for women, but for men, the scores are somewhat different, and scores are generally a little bit lower, scores between 5 and 6 representing that cutoff for anxiety and depression. And so as screenings are not diagnostic, it's important to take a look at that screen, score that screen, and then follow up on any positive screen with maybe a more complex measure. And there's a couple of inventories we talk about. One being the psychological assessment tool that has the PAT, which has rating scales and questions about symptoms of depression and PTSD. More information, as we've been talking about, that background, that family history and functioning, and then sort of other risk factors. So a little bit more of much more of an interview format. And another one, the clinical interview for premature parents, or CLIP, again, another semi-structured interview, and it asks about mom's feelings about pregnancy and delivery. We know that the pregnancy and delivery experience, or a mother's prior experience, father's prior experience with a hospital, can have a significant impact on their later adjustment and functioning. So the CLIP asks a lot of those questions. It asks about the baby's condition, the NICU stay, social support, relationships, and it also looks at readiness for motherhood. And an interviewer, after time, will become very skilled at recognizing symptoms of emotional distress in parents. And what's amazing is there's a very comprehensive review on screening tools written by Dr. Heinen and a few colleagues just a couple of years ago, back in 2013, on screening parents of high-risk infants for emotional distress. So if you want more detail on screening, I recommend that. I think it's really important that providers aren't afraid to screen. We talk a lot about don't screen if you don't have resources and referrals. And that's true. If you don't have resources to refer to, find them. Ask your psychologist, ask your unit social worker, contact the NPA, contact the PPA. We're going to connect you with those additional organizations who can find trained providers in your areas for parents who need these supports. And remember, you can never tell a parent's emotional state by looking. You have to ask. You have to screen. And we recommend, again, screening early and screening often.
So Mike, what would you add to that, when talking about, you know, some of the special considerations with these screenings and special populations and who we need to be paying attention to?
Well, I think that Sage has covered the data on fathers and special populations fairly well. So I'm going to divert your question a little bit and go off on a little bit of a tangent
Yeah.
and talk more about fathers within the NICU. Certainly fathers should be screened, but fathers have been described as kind of the forgotten parent in the NICU. And I think a way to help fathers' adjustment would be to provide for NICU fathers the same kind of expectations during a NICU stay that you would provide for the NICU mothers, and that it is very important to your baby's health and development that you come to the NICU as often as you can, that you learn how to feed and dress and bathe and provide support for your baby, that you talk to your baby, you sing to your baby. You are a very, very important person in this whole process. And I think that that can provide a good set of expectations and hopefully in the long run increase the frequency of fathers coming to the NICU and being with their children. So that would be my special thing to say about fathers.
Well, and it's so appreciated. I think your work that you've done and the attention you've paid to fathers and partners has really highlighted, first of all, just how, I mean, when you have a health crisis, and especially when you have a baby in the NICU, how complex the changes are to the roles that you have, what you anticipated being a parent was like, what you anticipated having a baby was going to be like, becoming a father was going to be like, and that interruption to it that happens when there's this sort of medical crisis and intervention is, that you often feel, I know I didn't feel like there was a roadmap for how to, this wasn't in the What to Expect When You're Expecting book. And I am so grateful, one, that we're having this conversation, but like both of you said, that there are resources and organizations. I mean, the National Perinatal Association and the Preemie Parent Alliance, all these organizations come into being because it's recognized that there's a need that's not being met. And I know one of the things that we've also tried to do within those organizations is not just the professional training and education development, these recommendations for what a NICU program that's family-centered and competent and informed by mental health needs looks like, but we've also done a lot to promote the screening tools and even self-screening. You can go to NPA's site and take various quick screenings to be able to then understand your needs and maybe go start a conversation with your professional, caregivers. But also then we link people to peer support, which again, the Preemie Parent Alliance and all the organizations that are a member, you're able to talk to somebody who can model for you what things might look like from here on out. And just, I mean, I think these conversations, whether they're with the psychologist or the social worker or the nurse or the peers or the family, we just need to be having these conversations. They're so important. And so it makes me think about, again, I think we all do the work that we do because, what do you do when you're a parent or you're a family and none of this is offered to you while you're in the NICU? So, my next question would be, first to you, Mike, is, if your unit doesn't have any of these sorts of programs, if nobody's having this conversation with you, if you start to recognize that you or somebody you love is being affected by this, what are the things that you can do to get connected with support?
I believe that there are a variety of things that parents can do both within the moment and over the long run. Within the moment of being in the NICU, it would be important to find a sympathetic ear or a champion and request what is viewed as that I need help right here. My wife needs help. And hopefully most NICUs will be able to provide that. But as I've evolved over time, there's I think a larger question about trying to ensure that support is built into every NICU in the world. And so in those instances, and certainly people within National Perinatal and Preemie Parent Alliance have had experience with going to NICU leadership and hospital leadership and starting conversations that essentially requests and maybe even demand an increased presence of perinatal mental health providers within the NICU. And in those instances, they can walk into those meetings, the parents can walk in with publications in hand, such as the psychosocial standards and any other number of publications. The hospital administrators may not be aware of these recommendations and the endorsement of organizations like National Perinatal. But to start the discussion, parents can ask for the sun and the moon and really not settle for less. And certainly we've experienced setbacks in attempts to do this, but parents are much more powerful than they generally believe they can be in terms of talking to hospital administration.
Yeah, I think especially it's something I've thought about a lot as within, medicine in the United States, we're talking about a shift in how we pay hospitals essentially and providers, which is based on the patient experience. And like you said, I don't think people often recognize what the power is that they have. And I'm really anxious to see how the change in the way that things are reimbursed for hospitals is affected by this kind of shift to the patient-centered perspective. I understand why people are afraid of it in some ways, but it has such tremendous promise for improving care and improving care of, the whole person. We try to care for the whole NICU baby. Our goal is to send home a baby who is healthy and developing well and intact and set up for success. And, this is what we need to do for parents to make sure that they are healthy and intact and set up for success. So, Dr. Saxton, what would you add to, this conversation about what you would do if you're not getting the support you need or there's not support in your NICU?
Absolutely. First, I think it's critical to pay attention to your parents. Support your parents. Don't ignore or hope that someone else will take care of that family. You will be able to provide that safe space. If you are fortunate enough to have a graduate parent network, make use of them. And with appropriate training and support, there have been a lot of successful peer-to-peer models out there. This isn't something you have to recreate. And I think that'll be covered likely more in the peer-to-peer module recorded session. Parents really need to feel comfortable in the NICU, otherwise they're going to be less willing, likely, to be present in the NICU. In general, you can simply ask parents how they're doing, making sure that you're using your inclusive language and asking to hear their stories. Ask what might be most on their mind in that moment. And I've had a lot of providers indicate they sometimes don't know what to say. And so a few trauma-informed examples might include something like, it seems like you have a lot of questions right now. I'm wondering if you'd like to sit down with myself or someone to focus on your questions until you feel like you've had a chance to have them all answered. I want to make sure you feel like we've addressed your concern. Another, again, looking at normalization, the NICU is a confusing place even for professionals. It's fine if you need me to repeat myself. Again, giving parents that permission to please ask again. So it's fine if you need me to repeat myself or if you have to ask me the same question over and over again. If it would help, we could come up with an alternative plan on how to manage information better for you. We could work on getting you a notebook or a recorder, but I really want to help make this information understandable and memorable for you. It's also important, if you don't have as much support in your NICU, to create a referral network, maybe a resource list that parents can take and review later. And that list, I would suggest including information on social media supports. A lot of NICUs now have parent web pages or graduate web pages for families. Any of those psychoeducation groups that are occurring in your hospital, especially again, back in those units with more than 20 beds. Any other peer-to-peer support networks or peer-to-peer groups. So peer-to-peer groups are not necessarily led by a professional or a trained professional. Therapy groups tend to be led by a trained professional. So talking about those available resources. And of course, the peer support specialists like the NPA, the PPA, as you were mentioning, Erica, as well as both information about warm lines. So warm lines are answered usually within 24 hours. A parent would leave a message and then a trained peer would get back to that parent, or a hotline, which are live answered 24 hours a day. And then any sort of telemedicine support. So making sure that all of those referral options are included in a list for parents. And then also maybe some of our national organizations such as Postpartum Support International, National Alliance on Mental Illness, Mental Health America, and one I really like to call specific attention to is a newer psychiatric consultation line through Postpartum Support International that is available for providers to call and consult about medications, medication changes, and medication impact. And then finally, I think it's really important, in addition to your own approach to families and support for families and that referral list, encouraging staff education. And the National Perinatal Association, of course, has psychosocial support guidelines for NICU parents. As mentioned earlier, Dr. Sue Hall has created a 7 continuing education online course for NICU staff to take. I think it's a 3-month access period. And also in-service training. So invite other psychologists from your area, people from other units to talk about family-centered care and infant-centered care topics at staff training days or competency days. We do a coffee and talk, or publishing information in a newsletter, weekly minutes just on staff education and support. And then finally, as Dr. Heinen mentioned, parents are really in a very strong position to demand additional supports. Start the discussion and ask for what you want. Ask for your unit to hire a psychologist and mental health specialist. And there's a great PDF called Talking Points about hiring a psychologist for your NICU through the Support for NICU Parents website. And that just lists bullet points that you can take to your administration about why a psychologist would benefit your unit.
I have one last question about parent leaders. So what would you say to a NICU parent leader who has been asked to participate in a project or a work group, but they just don't feel confident that they have anything of value to offer because they don't have a medical or clinical background?
Oh, I would personally hope that that parent leader would join whatever project they were invited to and provide that critical parent voice. Parents who have experienced the NICU have a very unique perspective. In my hospital, we require the parent perspective on all of our committees. And thankfully, we have a very active parent network that can do that. But the parent voice cannot be undervalued. It is so critical, and parents are really experts by experience. And I think that will help guide and inform, that expert by experience will really help guide and inform our programmatic efforts, our development efforts, our support network efforts in the NICU. And for parents, parents too might want to obtain some of that ongoing education through connections with your local networks, your psychologists, your mental health professionals, your parent-to-parent groups. And there's also some, of course, conference presentations, online trainings, and there's a lot of specialty training. Again, Postpartum Support International offers a 2-day perinatal mood anxiety disorder training, and then an advanced training, a 3rd-day component. And then if you take both, you're eligible to become certified in perinatal mental health. And as I mentioned, that other continuing education course by Dr. Sue Hall would also be available for NICUs, and we have encouraged that anyone involved in the NICU, not your active parents, but perhaps some of your parent support, parent advisory council members might be able to take that. And in addition, anyone's welcome to contact me, especially if you're a psychologist, and I can connect you with our NICU psychologist group. And again, there's that talking points list on PDF on the Support for NICU website. So please don't be afraid. You're experts by experience, and we welcome your perspective and thoughts in everything we do.
Thank you so much. And I think as we close, I'm going to put you guys on the spot for a minute. So in a moment, I'm going to ask you a question about what are the most important things you want parents to remember from this and providers to remember from this. But before that, I'm going to say for a minute, you know, what I take away from this conversation. And one of the things is that there are so many resources available, and there are so many organizations doing really, really good work, whether it's, like you said, PSI with their training, or Preemie Parent Alliance with promoting peer-to-peer support, and NPA, you know, kind of elevating the conversation to come up with, you know, what are the standards for evidence-based care. But there are so many ways that we can support families, and yet how hard it is to see that when you're in the position where you're the one that needs support. And I think that the work we do as advocates is so important for that reason, that we normalize these conversations, that we help families know what to expect, that we train providers to be able to meet those expectations. Because, you know, this having an experience like having a child in the NICU can be one of those really formative periods of your life. And it's this window of time that we have with families, whether it's the perinatal period or the time when they're in the NICU, can really transform the way they see their family's health and their own health and their mental health. And we can really model for families what this can look like when it's done well. So I really, really appreciate this conversation so much. But I'm going to put you on the spot first, Dr. Heinen. If there were one or maybe two takeaways that you want people to have from this discussion, what might those be?
Well, one takeaway would be that if you are a parent in the NICU and you get invited to serve on a committee, so once you've got your foot in the door, then being on that committee over a period of time, that as a parent advocate, you make yourself indispensable to that committee, so that doing some good productive work, you essentially end up removing the door. And I would advocate that parents think of themselves as moving into positions of leadership within the NICU and the hospital, and in the long run, becoming a chair of that committee. And even though that may sound bold, all parents should realize that networks, huge networks like Vermont Oxford, have parent leaders of chairs of some of its major projects and work groups. Mm-hmm. And so this is all very, very possible.
Well, I know that that's certainly what you've modeled for me and for Kira Sorrells and for other parents. Is, you know, their parents and families have such strong leadership capacity. And I'm very, very grateful for the work that's done that has elevated the voice of parents and included, I hate to even say included them at the table because of course they should be at the table. But how one of the things about advocacy and being a parent leader is you just show up. You show up and you do the work. And if they don't offer you a chair, you pull your own chair up to the table and you do it. And you, Mike, and also Becky Hatfield, who I know you've worked with a lot early on, supporting family advocacy, have really set that example, that standard for us, and made it possible for so many parents and families to get involved in this. And I just want to, recognize that and thank you for that. So Dr. Saxton, have you thought about it? If you had one or two things that you wanted to make sure that people thought about, what would they be?
I think it's important to realize that everyone in this field is so passionate and we all care. We're bringing a lot of this out of the dark into open discussion and normalizing the experience and finding ways that are providing supports to our families and engaging and engaging our families in increased involvement. It really is going to take a village. I think we've done a lot in the last 15 years on this topic, and there's still so much more to do. I love when my parents get involved and are advocates for the unit, and they're so strong, and they really bring us all up. So I think, again, we are at a really amazing time, and there's still more work to do. So please join us as we do that.
There's no doubt that there's work to be done, and again, this has been a fantastic conversation. Thank you so much for having it with us today, and I hope it's one of many conversations that we continue to have. Again, we'd like to highlight some of the resources that we've talked about during this presentation. One of them is the online course that was developed for staff education. We didn't mention, this is also something that's available for parent advocates, and we happen to know a lot of people who helped create it. And if you're a parent advocate or a parent who's interested in advocacy, please contact us. Please contact My NICU Network, because education opportunities are there and available. And if this is something you'd like to learn more about, we can make that happen, and we can remove whatever barriers you might feel are in place to being able to access these opportunities or curriculum or materials. The other place that I would tell you to visit are the sites that we have listed here. National Perinatal Association, that's the organization that I've grown up in the last couple of years, is a wonderful place to go for interdisciplinary perspectives. It is a professional and parent organization that takes the expertise and knowledge from all the different realms of care, whether it's neonatology, gynecology, psychology, social work, all of these things, and brings those perspectives and those people and providers together so that we can generate recommendations that are truly comprehensive, like the recommendations for psychosocial support. The Preemie Parent Alliance, again, is a fantastic place. If you are a parent advocate, if you're interested in parent advocacy, there are opportunities to learn and to grow and to network with people. There's no need to reinvent the wheel. There's no need for each of us to start alone in doing this work. This is a place where you can go and get guidance and support from people just like you who care about things that you care about. The companion website that came out of the publication of the recommendations for the psychosocial support of NICU parents is supportforNICUparents.org. We've referenced a couple of the things from that site. Dr. Saxton was talking about, if you wanted to make the case for the support of hiring a mental health care provider for your NICU, you can go to this site and you can find talking points and information and research and bibliographies to back up making those sorts of requests. There's also a lot of really wonderful materials on evaluating the standard of care in your NICU. Are you delivering family-focused, family-centered, family-driven support in your NICUs? My NICU network, we mentioned, that's where you can go for online education. And we also talked a great deal about the training offered by Postpartum Support International. Their website, postpartum.net, also has those hotline and warm lines that Dr. Saxton mentioned. So if you know a family, or if you are a family or a parent who needs support, it's not any more difficult than picking up the phone or dropping them an email, and you'll get connected with what you need. We'd also like to tell you a little bit more about what we do. This year and every year, the Preemie Parent Alliance hosts a summit that is usually a 2, sometimes 3-day summit where parent leaders and parent advocates and those who are interested in the work get together and discuss best practices, where we get technical support, where we meet each other and collaborate and work together. And nothing really replaces these sort of opportunities that you can have when you meet face-to-face with people who are doing the same work that you are. So we encourage you to find out more and to consider attending one of these events. The National Perinatal Association's advocacy arm for families is the Family Advocacy Network. And again, this is something that has come out of the wonderful work done by people like Dr. Mike Heinen and Becky Hatfield and others within the National Perinatal Association, like neonatologist Chris Glick. Early on, many years ago, as NPA was being founded, they recognized how important the parent voice was. And NPA is one of those organizations that doesn't just talk the talk, they walk the walk. We have parent board members, we have parent leaders, we have parents who are the heads of committees. So if you really want to do important and collaborative work, this is someplace where you can go, where you know that you'll be more than just that parent that's there to tell their story and to thank the providers who supported them. Instead, you'll be sitting side by side with them, creating the sort of guidelines and recommendations and programs that improve care. If you've enjoyed this, we hope you've enjoyed this discussion. I've enjoyed this discussion. We hope that you visit our companion website to this series and look at the other interviews and webinars that we've done talking about all the many different domains that are covered in the recommendations for the psychosocial support of NICU parents. We referred to them, but you can go and you can learn more about NICU staff support. You can learn more about peer-to-peer support, developmental care, palliative and bereavement care. There are so many things that are covered in these recommendations. And we've been fortunate enough not just to have smart and thoughtful authors on these recommendations, but to then now be able to sit down with them and have follow-up conversations about how we take these recommendations and put them into action. We hope that you will learn more about that. As always, thank you. Thank you for the work that you do every day. Thank you for showing up and for being a part of these important initiatives and these important conversations. We appreciate you, and we hope that you appreciate this. And if you do, we really invite you to please consider becoming a member of the Preemie Parent Alliance and of National Perinatal Association. Thank you so much, Dr. Heinen, Dr. Saxton, Allie, my co-host. Thank you so much for sitting down having this conversation with us today.